It's my pleasure right now to welcome back one of our colleagues who is also a Harvard Leeds Fellow, Marie Roseline Bélizaire. She is the head of the WHO emergency response. She's also joined here by two other colleagues, Ibrahima Salsifa, who is the former ADG for emergency response, and Dr. Dick Kalama from WHO Africa Programs Area Manager for Preparedness. Before I hand over the floor to Marie, let me just provide some background about her. She is a civil servant with more than 18 years of experience in public health at both national and global health levels. In Haiti, she worked as an HIV/AIDS medical officer, where she advocated for a holistic approach that included traditional healers in case management and expanded access to antiviral treatments in rural area in Europe. She worked as a senior public health expert for the project EpiSouth, which aimed to strengthen emergency preparedness in 27 countries in the Mediterranean region. As a scientific manager of the European projects, she promoted a resilient approach to non-communicable disease across the continent. She's also been working with the WHO since 2015, first serving as a team leader of the health emergency program in Mauritania, and now as well as an incident manager of large and complex outbreaks in several countries. As I mentioned, she's one of the world leading experts on this topic, and it's my pleasure to hand the floor over to her as she, give us an update of the Mpox response and discuss the community engagements during health emergency. So Marie, the floor is all yours.
Thank you so much, Phuong, and thank you also for the HHI family for having me for this webinar. So in this slide, we can see that in recent decades, the world has witnessed an alarming increase in the emergence and reemergence of infectious disease. So we have seen that this reemergence has been driven by factors such as global travel, urbanization, climate change, and the breakdown of public health infrastructure in some places. So those diseases like influenza H1N1, Ebola virus disease, Zika, polio, and Mpox has been declared public health of international concern since the adoption of the International Health Regulation in 2005. So these trends highlight the growing needs for robust surveillance system, preparedness, and rapid response strategies, but overall, the need to engage the communities in responding to public health emergencies that they can protect their health. So what is the current situation of the Mpox? So before that, I would like to give some, history and also what is the disease. We can see that Mpox is a zoonotic viral infectious disease. It was identified for the first time in 1958 in monkeys. And the first human case was notified in 1970, like 12 years after, in the Democratic Republic of the Congo, or DRC. So the disease went to emerge in other East, Central, and West African countries, and outbreaks have occurred in more than 100 countries in other regions since 2022, when the outbreak was declared public health of international concern for the first time. So Mpox can spread from person to person, human to human, and this spread can be done by close contact with someone who is infected. Close contact includes, I can say, being face-to-face with someone, such as talking or breathing close to someone, which can generate droplet or short range of aerosol. It's a close contact also means skin-to-skin contact, such as touching or vaginal anal sex, mouth to mouth, such as kissing, or mouth to skin contact, such as oral sex or kissing the skin. And it's also possible for Mpox virus to persist for sometimes on the clothes of some infected person, on the bed sheets, on the towels, and objects used by infected person by the Mpox. So globally, what is the situation? So since in this map, we can see that since January 2022, cases of Mpox has been reported in all the WHO region, in the 6 region. So 123 member states across the world report cases of Mpox. And as of 31st August of 2024, we have a total of 106,310 laboratory confirmed cases in the world, including 234 deaths. So the most 10 affected countries in the world are the United States with more than 3,300,000 cases, Brazil with 12,000 cases, Spain with 800 cases, the Democratic Republic of the Congo with 600 cases, France, Colombia, Mexico with 400 cases and more, the United Kingdom with 400 cases, Peru, and Germany. Those countries, those 10 countries by themselves, some 79.9% of all the cases reported globally. So in Africa, you can say that this is the curve of the epidemic curve of the outbreak since June 2022 till August 2024. So you can have that when you look at the epidemic curve of Mpox globally, you see that there were reported cases in America and Europe during the first phase of the outbreak, when it was first declared public health of emergency international concern. So this is the year when sexual transmission of Mpox was widely reported. So the 2022 outbreak promoted the WHO DG to declare a fake, following the advice of the emergency committee, of course. So from 23 to date, you can see that the epi curve has a very long tail, and that tail is that we are observing now in 2024, and it is the reason why we have another fake declared in August 2024. And now the increased cases is only or mostly in the African region of the WHO, and cases are reporting, as mentioned, Pham, in more than 15 countries in Africa. So just to get a little loop into the African context. So actually, Africa is the epicenter of the current outbreak, as shown in the epi curve you can observe now. So the DRC is the most affected country. DRC is the country in red, and 90% of the cases in that epidemic now in 2024 are reported in DRC. So after DRC, we have 15 other countries that are affected. Second one, we have Burundi that also affected with more than 500 cases. And we have also Nigeria. So what is really important to see now, we only have 32 deaths, okay, reported in Africa this year. So those data is only for 2024. So here, the only thing that I would like you to see to get your attention is the distribution on age and sex for the Mpox globally. So while you can see in that on that graph that more cases are concentrated in the range of age from 18 to 44, we also see that most men are affected in the outbreak. However, this is not the same trend that we observe in Africa. In Africa, you can see this is the curve for DRC from January to August 2024. You can see that most the cases in Africa are reported in women and children. This is an important as community engagement approach. Reason why I'm showing that, because the approach will not be the same when you tailored your response to the affected community. So how do we respond to emergency in WHO? So here I want to present you the aftermath of COVID-19 pandemic. So after COVID, we have the need to a new global health architecture that can address the lesson learned and recommend action to improve emergency prevention, preparedness, and resilience. This is why the HEPR was born. So there are more than 300 post-COVID recommendations that had been sent to WHO, and it is from the independent panel. This independent panel was chaired by the ex-Prime Minister of New Zealand, Helen Clark, and the retired President of Liberia, is Her Excellency Ellen Sirleaf Johnson. So the HEPR framework recognized the need for improving governance, financing, and systems that are interconnected to protect the health of the community. But most of I want you to see that is that the HEPR is based on 5 C's, what we call commonly the 5 C's. The 5 C's stand for collaborative surveillance, community protection, access to countermeasure, safe and scalable care, and all of that should be coordinated at local, national, regional, sub-regional, and global level in order for the community to access all those countermeasures. So, while HEPR provide overall architecture for the emergency response in WHO, so we also have the International Health Regulation, and WHO has mandate to strengthen preparedness and response capacity of all its member states that is governed by the International Health Regulation that we call IHR 2005. So the IHR 2005 is legally binding instrument. This is what we use to declare public health of international concern, is adopted by the 193 member state, and we use the ERF, the Emergency Response Framework, that are the way we manage the emergency. You have to note that the IHR was amended in 2024, and the new edition is still about to publish. But what I also want you to see is that we have a timeline when responding to emergency. So the timeline is that in the first 7 days, the event should be detected and verified. We need 1 day for the notification to WHO, and the next 7 days, we should work with the community to make the risk assessment and also to tailor the response and activate if the need of escalation. After that, we should review our response and to see if the community is resilient, and then we can declare the outbreak over. So how do we engage with the community? So community engagement, okay, is a process. So here I bring you 2 definitions or 2 concepts from 2 global health institution, WHO and US CDC. You can see that while the WHO define the concept as a process of developing relationship to address health issues, US CDC said this is the process of working collaboratively to address issues affecting the well-being of the community. So what is interesting here to see is that both institutions agreed that community engagement in health is a partnership and a collaboration with the community. So we have so many tools. As you can see, international institution, non-governmental institution, NGOs produce a lot of tools to inform the implementation of community engagement in health emergencies. So, but not only for health emergencies, because we also need community engagement for development, for climate change, for whatever that we are doing in the community. So we are not beginning from scratch. So there are a lot of tools that are already existing. We also have one of monkeypox that was published this year in April this year. It's very new, and the link will be shared after this presentation. So now, how do we translate all those information in those tools into practice? How do we make the tools becoming applicable in the community? So when you are the first time deployed in community, the first thing to do is the mapping, analysis, and understanding your community. So what do you have in front of you? What kind of community do you have? You have to find your community of interest. How many religions do we have in that community? Where are the churches? Where are the mosques? Where are the schools? Where are the university? Okay, so how many community of identity I have? Where are the LGBTQ people? Where are they gathering together? So what are the community of places like the bar, the site for prostitution, those kind of hidden places in the community? And nowadays, we also have an online community that is not negligible, because with the boom of internet and social media, this community has a direct impact in your intervention in field. So we should also map that community in your kind of community. After you map the community, so you should go to analyze the community. The framework that we use to do that is the PESTEL framework. So the PESTEL framework is like you have the political aspect. The P is standard for political aspect. So the political aspect, you should know, is there any local election ongoing in the community? Do we have any campaign ongoing in the community? And the E is for economic. What is the principal economic source, financial source of the community? Does the emergency has a direct impact? So now the community will hide the cases because they don't want their economic to go, to suffer. So after that, we also have the S for sociological factors. What are the beliefs in the community? What is the culture? Is the community open? Okay, is a closed community? Do they go to traditional healers before coming to the medical doctor? So what they are doing? What are the social behavior of this community? We also need to know what is the technology in the community. Is everyone listening to radio? Does everyone has at least a TV channel? So how can I reach this community in terms of technology? Are they really like Facebook? Should I post in Facebook in order to reach them? And we also need to know the legal issue. Who is the highest, administrator? Who is the elected person in the community? Who are the community leaders? And finally, we also need to know the environment. Is this community can suffer, for example, floods during the outbreak response? So what would be the environmental factors that could modify my response? So after conducting the PESTEL analysis, we use another framework that we call DDDIE model, is to understand the behavior in your community. You have to define in terms of behaviors, okay, what is driving the community by? Diagnose the barriers. What would be the barriers if I'm going to the community? Design the strategy to influence their behavior. And the strategy should also be defined with the community. implement the strategy together with the community, and after all, evaluate. As you can see, the cycle is not ending there. You have to come back to reevaluate your strategy, to re-implement, but every time should be together with the community. So the community engagement, as we said before, is a process, okay? And each process has steps. Here we present to you 4 steps, as for not to forget. The first step is to establish the dialogue and building trust in the community. The second one is to set the stage. Where are we coordinate with the community? The third one is to gather the fact, the brainstorm, and also to listen to the community. When you're going to the community, it's important that you listen more and you talk less. Okay, listen what moves the community, what makes the heart of this community sing, what they are living for. And finally, we have also to implement and evaluate. As I said before, this is a cycle. As you finish, you should go to the first step, because the building trust is a continuing process. So here, it is also to tell that the roles and responsibilities should be shared with the community. The community has a role in all the steps of the emergency response, in the anticipation step, in the detection, the notification, to response, and also in the resilience step. But our responsibility is to empower this community, to give them the tools that they need in order to be a good collaborator and also to have a good partnership established with the community. So with COVID-19, we saw that there is a lot of infodemic management. What is infodemic? It is the flow of information that you cannot control. The information can be good or bad, but it's so, enormous that you cannot control it and you can misuse them. So with COVID-19, we now establish the infodemic management. And the experience shows us that the best infodemic manager is the community, because they are those using that information, okay? So if you work with them, you will not have any issue in order to manage your information. So this is my slide, my last slide. And this slide here, I will describe my experience in community engagement in the field doing, so many emergency response like Ebola, yellow fever in Angola, dengue in Mauritania, in Cuba, and so many other outbreaks. So this is really what I want to share with you from my personal experience. So the first thing I want to tell you is to be humble. You should go where the community are and avoid a stigma. In a disease like monkeypox or Mpox, you see that this is the skin disease. So this person affected by Mpox will stay for life with their skin, with that, affection. So it's really important that we don't show them that we are afraid of talking with those people. We are not afraid of approaching the community because of that. Of course, you have to take your measure. You have to respect the distance. You have to observe also all the measures that you are, recommending to the community. You also have to observe them. So I take one of the picture in the in the left is where I was going to the forest, in the equatorial forest, looking for those people that are living inside the forest, because there was an Ebola outbreak. Everyone was at risk, so I should find everyone there. The second one is to show respect to the community leaders and the entire community. Don't go that you are the one who knows, you are the one who have the knowledge. No, you should listen to those community, as I said before, and talk less. You should also be an active part of the change you want to see. As I said before, you should observe the health measure that you are promoting, that you promote in the community. You should address their concern timely, using their own words. in one of the picture, you can see I was talking with a group of people. It was because a rumor come to me that women don't want to get vaccinated against Ebola because the vaccination will produce infertility. And the rumor was ongoing, and the rate of vaccination was decreasing. So it was important that we meet with that community in the same time that the rumor was ongoing in order to provide them with the information we have and also make some negotiation with them in order to get vaccination. So you are in the community to control the outbreak. You are not in the community to control the community. So the measure that you are putting in place shouldn't be to make the community changing their, I mean, not the behavior. They should change their behavior toward the disease, but don't change the community life. Don't tell them you shouldn't do that, you shouldn't do this. Try to see with them how can you adapt the response strategy to the specific needs of the community. That means there is no response fit all in emergency, even though you could use, I mean, the scientific result, but you should tailor each response to the specific community. You should show compassion to the community. I remember I was talking with a community member and I was telling him that Ebola is in the community. And the community member told me, oh, actually Ebola is a disease. Normally as a human being, I should be dead by a disease. And I said, no, he said, yes, because actually in my community, we are being killed, okay, by armed group, we are being killed and there's nobody doing anything for us. I would prefer me to be died, okay, by a disease. So in front of that situation, before trying to convince that person to protect himself against Ebola, I show compassion. I explain that person that my role is not security, okay? But I can use my voice to make his message going through those responsible for his security. But me, I'm here to protect him against Ebola. So the other things also I would suggest is that we should be culture sensitive. Culture sensitive means be aware of the belief, okay, in the community. In one of the picture, you can see that I was in a body bag. It was because in the community, they told me that when I put the dead body in the body bag, the soul of the dead person is staying on earth, is not going to the paradise. Well, what should I do in that? I show them that when the dead body is in the bag, there is nothing happening. It's not the bag causing the bleeding of the dead body. It's the disease, it's the virus. However, they negotiate with me if I can leave a little space of the bag open. So now the soul can go outside. We agreed on that. We agreed on that and we implement that in the response. And we have less resistance, okay, against the use of the dead body. So we have to show the example. This is the example I just show now. We have to change we are not there to change the belief of the community. This is very important. We are in the response to change their behavior toward the disease, okay? And the last thing also I want to say, and we need to celebrate the success and the milestone with the community. When someone is, is ill, is going back to the community after being cured from a disease like monkeypox, like Ebola, is a huge milestone for the community. And you can also use that in your favor to show that your response is getting results. And you have to celebrate those milestones with the community. So this is all that I have to share today. So thank you. And Pham, Professor Pham, over to you.
Thank you so much for this excellent and very clear presentations. We're getting a lot of requests by the attendees to have your PowerPoint. So that just to note that. But yeah, I want to open up to the audience to see if anyone has any questions. And as we're gathering some of those questions. Maybe I can ask you just a very general questions. Currently, what is the community reactions to the Mpox emergency right now? I think the top three countries you mentioned impacted by Mpox are DRC, Burundi, and Nigeria. All of them are in fragile states. And so just curious right now, what's the general reactions there?
Thank you, Professor Pham, for this question. Well, actually, as you know, Mpox is endemic in DRC and Nigeria. It is not the first time that they are reporting cases, but however, in Burundi, it is new. It is very new in Burundi, and it is spreading very fast also in Burundi. So in DRC, we have very good, I can say, community engagement ongoing so far. And a lot of partners were already working in that aspect since 2022, when the outbreak was first the fake, until now. We have so many activity ongoing to engage the community. Now, the biggest challenge is to accept the vaccination. That is also one of the tools that we'll be using during the response. But the experts are on the field. They are working close very with the community. The other aspect also we shouldn't forget about DRC is a country with a lot of emergency. Actually, this outbreak is also in the North Kivu and the South Kivu. They were affected by the Ebola. They are affected by the measles, affected also by cholera. So this community is really resilient. But however, Mpox is different because it's something that can provoke more stigma than others. So this is how the team is really focused in order to have acceptance of those people to declare, to get active surveillance, and also to have more cases detected. So very early stage before having the severe cases that I have in my presentation now. In Burundi, the same activities are ongoing in order to engage the community. But as it is a new disease, and it is also international, it is not only Burundi who has that disease. So there are more acceptance in the community to go to the hospital. But the challenge is still the same, the belief in the community. Those communities are still not getting to the health system timely. They are getting when the disease is really severe, all the body has already covered. And this is what we are observing now. Thank you.
Thank you so much for that. And, we have several questions. I'm going to ask them, I think, just because we just finished discussing about DRC and Burundi. There's a questions about what could be the reasons more females and children are affected in the DRC? And then I think while you're thinking about that, there's another question that says, can we have some example of response strategies or approach that led by community, which is very successful?
Okay, thank you very much. I'm going to try to respond to the question about more children and women affected by Mpox, because we had a similar question during the biggest Ebola outbreak in North Kivu. So when we analyzed the data, it was very surprising to see so many children affected. When we investigated, we realized that most of the children were affected through nosocomial transmission because they were going to the same health facilities. There is no infection prevention and control. And, with this vicious circle, because the women were taking care of the children, they got infected also by Ebola. So the same thing can happen because traditionally it's really the women who are taking care of the sick children. So when the children are affected, the mothers, the sisters, they can be easily affected also by the infectious disease. Thank you.
Well, and also to other question, what could be the reason? Yeah, I think Dr. Sosifal replied to that question, answer to that question. So example of strategies that provide a result, we have so many. One of them is, for example, the COVID-19 response in the Central African Republic, where we put in place a community-based surveillance strategy at the beginning, at very early stage of the response. And we work with the community because at that moment, there was no tools, there was no treatment, there was no protection, material protection. And the only tool we have is the community. So the community was used as a tool, engage them, explain them, and establish partnership with them. This is when we put in place that community surveillance. So the community were reporting all the cases, and they are also make a surveillance of vulnerable population. Vulnerable population, they target those who were affected by non-communicable disease like diabetes, hypertension, because those were more at risk to be died by COVID. So the community itself put in place that surveillance and report to us each time we have someone with diabetes and COVID. So as a good result, we can say that while it was, modeling that in the Central African Republic, we will have an hecatomb, a lot of people, we will pick up dead body in the street. At the end of the epidemic, they only have 113 deaths, more or less, you see? So this is, been a good result in a country where the health system is really weak and there is no infrastructure, there is no, I can say, economic, the community is a humanitarian situation, but using the community, engage them as giving that result. And we also have 70% of the target community who has been vaccinated against COVID-19, and they continue to get their vaccination because now this is the community leaders who are going from household to household to engage all their community. Over.
Thank you so much for that. We also now have several questions related to vaccine. So one question from Tom Mahoney is, how is WHO advocating for and implementing developments of novel vaccines and antiviral therapeutics for Mpox, with particular emphasis on the virulent clade 1B? And then I think the second question is related to that too, is by Adam Abdullah. Are vaccine rollout part of the control strategy and included as part of the community engagement strategy? If so, how confident are you that the immunogenics and robustness of the Janus vaccines are being rolled out across the regional, especially given the limited empirical data from the African population?
Okay, I can start. In terms of advocacy for vaccines, this has been a big issue for WHO. Even before the pandemic, of course, it was really at the center of the discussion during the pandemic, because we realized that African countries have little access to new vaccines. And as part of the WHO Health Emergency Program, we had set up what we call the R&D blueprint for epidemics, where we facilitate, testing of new vaccine, like for Ebola. It was us with our team, really, led all the clinical trial to approve the vaccine. So when COVID-19 started, we used the same platform for the new vaccines, but clearly we were not able to ensure access to vaccine to everywhere where it is needed in Africa. So that's why working with the African Union, African CDC, WHO advocate for access to vaccine in DRC. And last week we have seen the first vaccine going to DRC, but it's still not enough. The bottom line is Mpox was neglected because it was only happening in a very limited area in Africa, and there was no clear investment into availability of vaccine for Africa. But the effort will only accelerate in 2022 when we started having cases in Europe and in the Americas. This is something we need to change if you are serious about universal health coverage, about equity for vaccine, and so on. Thank you.
So, and regarding also the Mpox vaccine, so at present, WHO recommend the vaccine that called MVA-BN or LC16. that it's recommended. But in places where those vaccines are not available, it's also recommended the ACAM 2000, ACAM 2000 vaccine when this is not available. So for now, we are working also with other countries that are giving in their stock of vaccination. Reason why you see, for example, we receive from the European Union, like from Spain, we have from the US. There are a lot of I can say solidarity that is ongoing, that WHO is promoting for countries who have stock that they are not using, or stock they can replace after, so they can give that to country in need actually. So this is how Dr. Sose said that a vaccine has arrived in DRC from that strategy promoting by WHO. So there was another question I didn't hear. If you can repeat it, please.
Yes, so our vaccine rolled out part of the control strategies and included as part of the community engagement strategies. And if so, how confident are you that the immunogenicity and the robustness of the genus vaccines are being rolled out across the regional or the regions, especially given the limited empirical data from the African population?
Okay.
Okay, it is important to explain the vaccination strategy we're using for Mpox. And if you look at the way smallpox was eradicated, it was through ring vaccination, meaning investigating around cases, vaccinating the contacts and the contacts of contacts. And we have used the same strategy for Ebola in DRC, the ring vaccination. So what is specific for Mpox? We are going to use the ring vaccination, but at the same time, targeted vaccination for children, between 0 to 15, of course, for health workers, because they are so exposed, but of course, for more vulnerable group like MSM and others. So it's very targeted. And clearly we need more, vaccines to be able to cover everybody who needs to be vaccinated. And we are very confident based on what we have seen for smallpox, what we have seen during Ebola, that we can stop transmission. It does not mean that, in the areas where we have the real virus reservoir, transmission will stop, but we can limit the spread of the outbreak to other places. And while doing so, it's also a form of clinical trial, because we need to collect more information on the African population to see the effectiveness and safety of the vaccine. So it's really another large-scale clinical trial we are going to conduct at the same time. Thank you.
I would like to add also that vaccination is not the only area of response in the emergency. So far we described there can be 11 or 12 area of response. We have the case management. We have also the case management when we treat the patient in a facility or also in community. With Mpox, we are also seeing that we have community case management when the patient are being treated at home. When the case is already, in a phase where there is no infection anymore, because if you're going very late to the health system and your vital system is not engaged, so the case can be treated in community. So we are seeing that. We also have the infection prevention and control area where we have to prevent. Dr. Sose mentioned children can be affected by nosocomial. Nosocomial is those infections inside the health facilities. When we don't respect the isolation, we don't respect the precaution, you don't wash your hand before touching a patient, and also transmission can occur in those aspects. We also have the community engagement. Community engagement is one of the most powerful tools to control outbreak. We have seen so many outbreaks has been controlling without vaccination. Thankfully, we have the vaccination, we will use it, but we shouldn't be telling in mind that vaccination is only tool that should be used in an outbreak. We should also use other tools. As I said before, we also have other area of response that I don't need to mention because I will take too much time. But we should know that vaccination is one of the 12 area of response in the outbreak. Thank you.
Thank you so much for that. And, just another questions here, and I think this is related to your last comments. One is, how are we supporting affected countries and regions? And are there supporting mechanisms like improved surveillance, readiness and response, and case management? And then another vaccine-related question is, what is the target age for vaccinations? I think the professors already mentioned that, but if you can repeat the response for the target age of vaccination as well.
Hi, everybody. I will actually start, and I will hand over to actually others, as I'm the person who I'm in Africa now. In Africa now, how we've approached Mpox is that we are collaborating with the regional agencies, entities, and one of these regional entities, Africa's CDC, in which we have created the Continental Strategic Preparedness and Response Plan, in which it has areas in which you have heard here actually discussed earlier. And among the areas in which we've added at the moment is the area of the readiness in the countries around the hotspot areas in order to prepare other countries to respond if they have importation of the virus. The main areas of priorities, I think, include coordination. I think it's been already discussed here. There's a case management is also another areas of work. We have the area of the vaccines, in which we've already talked about it. And I think we've all heard that there had been a donation from actually European Union, in which Africa region has received almost 220,000 doses of the vaccines for Mpox. And also we have expectation from another donor, Japan, who has promised to have actually donation to Africa of around 3 million doses of the vaccines. So we don't know a timeline yet of having these vaccines, but we have also other areas, the community engagement, in which we have heard it here also from Roseline, early warning, and also actually area of the data, logistics is actually a critical part of us, and we're doing that. So the strategic preparedness and response plan is clearly articulating which agency is responsible or to do actually what. And we've created, in order to implement our activities and supporting our countries, we've created a continental incident management team, in which it has coordinators and a number of pillars, and each of the pillars actually have the head. So each of the countries or priority countries in Africa, we have supported to create the national specific plan, in which is actually attempting to contextualize the continental plan in their countries. And also we've started the deployment of experts from outside, particularly in the regional office, and actually other agencies outside Africa also as an expert to support the countries. The other area is to mobilize appropriate resources. You should know that the continental plan is estimated to cost around $500 million. Therefore, it isn't really a small amount of money. And we need to have a number actually of the donors who will be able to support us in our action. I hope I will end up here in Africa context, and I will hand over to you, Roseline. Over.
Thank you. Over to you, Professor Phuong.
Thank you so much for that excellent response, and I really enjoyed all of the expertise that's provided here. I think there's a lot of questions about the vaccines and the community engagements. Going back to, you know, the issues of vaccinations, you mentioned recently there was a huge donations by several countries. Could you discuss, there's been some communications about the different modality in which those are administered, and what are the strategy now with the different modality of the administrations of the different vaccines, especially the more recent one that's donated by the Japanese government?
Yes, I think you have really hit at the point that EU vaccine is actually a 2-dose, a regime one, a Japanese one, it will be a 1-dose. However, the vial in which it comes with, it has a number actually of the doses. And also it need a bifurcated needle in order to actually apply a vaccine. And the other issue is it had the live actually virus. It means that for those people who are immunocompromised, they might actually have issues or they might have reaction. So the DRC, the Congo, I think in May, I was in Kinshasa. It was starting to do a clinical trial actually to see actually some of the various strategies in which we'll be able to actually implementing this. So to answer on you is true because it is the virus, the life, you have to understand in other areas, example in Africa, the status of patient with HIV or any other diseases in which is immunocompromised, and administration of the needles is actually a subcutaneous in which also it needs really specialized or a training to administer that. So it brings an issue of how are we able to train our health workers on time in order to administer actually a vaccine. But also the area strategy was to repurpose the actually polio staff, who we have over 290 of them in the country, and see how are they able to be retrained and actually administer. But as you know, a polio is administered orally. So here now we are really talking about another way. Is a reason it actually is an issue in which we're talking. It isn't easy as how the people actually talking. And in the DRC also, we have areas like in the North Kivu in which we have the conflict with active war there happening. It's actually another issue we have to it's actually another issue in which it brings a problem in the logistics and supplies and even administration of the vaccine itself. Over.
Over to you, Professor Phuong.
Thank you so much for that. I don't see any other questions. Is there any other questions that anyone wants to raise? I think if nobody else have any questions, I like to just send a sincere thanks to all three of you, Dr. Abraham Sasifa and Dr. Dick Shamala and Dr. Marie Bélizaire for really wonderful presentations and also insightful response to all of the Q&A. We wish you the best of luck in this response and all of you, the other emergency that you are responding to. And thank you so much for taking time out of your busy schedules to join us here today. On behalf of everyone, I'd like to also thank everyone who attended, taking their time to attend this event. And thank you so much. We will be posting this presentations online, and we'll follow up with another seminar on Mpox in a couple of weeks. But thank you so much for everyone for joining and taking their time to be here with us today.
Thank you. Thank you so much.
Thank you.